I'm happy to be here today to share with you some of the preliminary results from the ManCount Survey. I'm one of the principal investigators on the survey, and I'll be sharing with you some of our preliminary findings related to HPV infection and anal dysplasia. So as you saw all the logos on the front page, I just want to acknowledge that the ManCount Survey was a very big effort and involved a lot of people. We had a lot of team players, a lot of different agencies around the table, and really it was the acknowledgement of many of the people here in the room actually in getting it going. In particular with the HPV component, this is what I'll be talking about today. We had some unique partners with the Cancer Agency and at the National Microbiology Laboratory who helped us to deliver this part of the study. So I think many people have probably heard about MTRAC or ManCount. We've presented on this previously at the summit. But the ManCount survey is how we branded the Vancouver site of the MTRAC surveillance system, which is a national surveillance system in Canada. And it's a surveillance system that combines both HIV surveillance and behavioral surveillance. And the way it works is recruitment of men occurs at gay community venues, groups, and other events. Men who agree to participate complete a questionnaire, and then survey staff collect a blood spot, which is then tested for HIV and other sexually transmitted infections. In Vancouver, men were eligible to participate if they identified as a man who has sex with men and were at least 19 years of age. We conducted the survey between August 2008 to February 2009, and overall we had 1169 men, which we were quite happy actually to have that many men over this time period, of which almost all did contribute a dry blood spot for analysis. Now, to sort of just take a bit of a sidestep, Natasha was telling you about the anal pap testing and the procedure you go for an anal pap test. We sort of more broadly speaking, men can take the swabs themselves, and so what we'd call a self-collected rectal swab. Like testing for the changes of anal cancer, anal dysplasia, you can also test for HPV, Chlamydia, gonorrhea, as well as other viruses. As Natasha had said, in general, these are conditions which do have a high prevalence amongst gay men, and particularly amongst HIV-positive men. Self-collected specimens are, in general, considered to be equivalent to provider-collected specimens that are collected in clinics. And we used a self-collection methodology which had been previously developed by Tom Lampton and his colleagues at the Center for Excellence as part of the Vanguard study, where they compared self-collected to provider-collected swabs amongst participants in Vanguard. So what we set out to do with the ManCount survey was to actually include the self-collection of rectal swabs as kind of a sub-study within the larger study. And we had sort of our main purpose was to really use self-collected rectal swabs in order just to really measure what's the prevalence of HPV, Chlamydia, gonorrhea, and abnormal anal cytology, the kinds of cellular changes Natasha was talking about amongst MSM in Vancouver. And really we know that by including these swabs within ManCount survey, we were also then able to look at the questionnaire data and the blood spot data in addition to the self-collected rectal swab data. So there's actually a lot of richness in this study design which allowed us and will allow us to look at some different questions. We did this on a subset of participants. We started doing this a month after we launched the survey, between September to February. And the way that we did this is we didn't want this to jeopardize anyone from participating in the survey. So at the end of the ManCount survey, after the questionnaire had been completed and the dry blood spot collected, we asked men if they'd be willing to participate in a second study. If they did, then we proceeded. Men were generally presented with two options, although the first was definitely stressed, which was when there was a bathroom on site where men could go to self-collect themselves, that was encouraged. That was sort of our option one. Where there wasn't a bathroom on site or where men weren't comfortable with that, there was a second option where men could follow up at a series of 8 sort of clinics and agencies sort of in the Vancouver area at a later date in order to participate and provide a swab. They were given a self-collection kit, which is over there on the side, and essentially what it involved is there was a sheet of instructions, which were reviewed actually with them by the survey staff, which demonstrated how to collect the swab, which was then inserted in a thin prep vial Natasha mentioned earlier, containing alcohol, put in the bag, given back to the survey interviewers, and then sent to the lab for processing. And testing was done for HPV, chlamydia, gonorrhea, and cytology, and actually the testing was done at 3 different labs, so there was definitely some logistics that were involved here. So just to summarize our results from this, so with this subsection between September and February, we approached 766 men after they finished the questionnaire and dry blood spot and asked them to participate, of which 35% consented to participate in this sub-study. Most did consent to providing a specimen on site, 92%, with 21 or 8% consenting to following up at a secondary site. But as you can see, having an on-site bathroom obviously made a huge difference, where we were able to collect a specimen from everybody on site, whereas only about a quarter of men actually did follow up at a secondary site to provide the specimen. So in total, we had 252 specimens, of which, for various reasons, about 95% of them actually had enough quality. There was enough volume in the specimen that we could test them. So just to provide you quickly, what are the preliminary results? So one of the things that happens when you have an anal pap testing, you look at the smear, is that the cytologist tells you whether it's actually adequate for interpretation or not. So is there enough cells that you can actually say one way or another what the results are? And one of the findings that we found in our survey was actually, if you look at the unsatisfactory for analysis, that 38% of the specimens were unsatisfactory for the analysis. And this was a bit of a surprise to us, and this is different from what you see in many other studies, including the study I mentioned earlier as part of Vanguard, where it was 17% that had results that were unsatisfactory for analysis. And this was a bit unique, and I think it's one of the unique findings of the survey. And I think there's probably a lot of explanations for this. I mean, it's very different collecting a swab in a bar versus doing it in a clinic, for example, or in some of the home-based surveys. And this was also probably men were tired after doing a questionnaire and blood spot. It may not have been fully inserted, although we did periodically reinforce that during the study, and it didn't seem to make much of a difference. If men had used, for example, lubricant or had douched probably in the previous 12 to 24 hours, that may have had an impact. And we know that not all bathrooms are created equal, and so there was probably some environmental factors that had an impact on how well men could participate. Sorry, it's a lot of data, and I'm happy to provide this to anybody afterwards. But what this shows is kind of the results of the PAP test, essentially. With normal cytology, or the negative result, about 58% overall had a negative result. The way these results work is that the number that's in bracket is the 95% confidence interval around the estimate, so it gives you a sense of the range of where the value might be. So if we look at the total sample then, this is just on the specimens that were adequate, 149 specimens, that 11% overall had high-grade squamous intraepithelial lesion, and then 20%, 90% had low-grade, with the atypical being 12%. And you can see that there are clearly some differences by HIV status, similar to what Natasha was saying earlier, with the prevalence of high-grade and low-grade being higher amongst HIV-positive men. And just for comparison, in pink are just some of the numbers that have come from other studies, to be compared with some caution, because they're often in different settings, different populations. But in general, sort of what we find here is similar to what we see in other studies from other jurisdictions. But this is giving us now local data. For the other piece I'll present is just HPV infection. So in addition to looking for the cellular changes, you can actually just test for the presence of the virus and to see if it's present or not. When you're doing an HPV test, it's a genetic test, so you're looking for the virus. What they do kind of as a marker to see how good the specimen is that they test for something called the beta globin gene. And again, it's kind of like a marker of adequacy. So it's similar to what they do with the cytology changes, where you're looking to see if it's adequate or not. And again, what we found here is that 33% of specimens were beta globin negative, which would generally be interpreted as it was probably not an adequate specimen. So again, it kind of confirms what we saw earlier. But what we see in terms of the HPV infection, and these are structured the same way, and this is now on 159 specimens where the beta globin gene was found, so the adequate specimens, that the overall prevalence, so that 38% of men were HPV negative, so no virus was found. That 37% of men had one or more low-risk HPV types, so these are the types predominantly associated with genital warts, and 47% of men had one or more high-risk HPV types. And again, you can see the differences by HIV status, with HIV positive men being more likely to have both low-risk and high-risk HPV types. So, so these are some of our conclusions. I mean, we've demonstrated that in community settings you can actually collect specimens like this. I haven't seen very many other studies that have done it in community settings, but I think one of the clear limitations may be that you may have an impact on specimen adequacy. So that may limit your ability to, the utility of the survey. However, we have now shown, at least, that our prevalence estimates in our study are similar within the same range compared to studies from other jurisdictions. So now we have local BC data on the prevalence of HPV in anal cytology. the number of specimens is small, so that's why we have the wide confidence intervals. And just to emphasize that right now these are preliminary results. So these are kind of hot off the press. And we'd have to do further analysis. So we have to think more carefully about, how do the men who participated in the self-collection part differ from men who did not? And is there any factors there that may influence the conclusions that we draw? And also to look more carefully at obviously that the option 2 wasn't very good. And so if we eliminated the impact of, or eliminated the men who only had the option 2, perhaps we might have different results. So these are just some of the kinds of things that we'll be looking at. But hopefully we'll be seeing some more findings or some more reports coming out from our study team related to HPV and anal cytology. And as I mentioned, we can look at our questionnaire data and our blood spot data to look at in more detail. And I guess, you could really, part of it is a little like ho-hum. We found the same prevalences as in other jurisdictions. What's the point of really doing this? And in some respects, it speaks to some of the threads that have happened here at the conference already about the importance of having data, even just so that you can use data for advocacy. And really, the whole intent of doing this and our goal behind doing this is to inform BC policy and program discussions about both the HPV vaccine in men, and then perhaps around anal dysplasia screenings for the anal pap testing amongst gay men and other MSM in BC. So really, one of the nice things about our survey is that we have a number of different agencies around the table, both government and community, and I think part of why we did that was so that we could come together around issues like this and really try to sort of advocate for some of these services which aren't as available. So I'll just close there. Our website, will be starting to post some of these results on our website as they come out. So please stay tuned for these and other reports when they come out. Great, thanks.